all of us are quite aware that immunosuppressants always increase the risk of infection. So whenever there is a risk of infection or a patient is already suffering from some or a particular infection, in that case, we always try to avoid the immunosuppressants. Initially, we thought that during these times of COVID pandemic, even this fact would stand true for COVID or the coronavirus as well. So we thought that okay, the immunosuppressant should not be used. And during initial days, even a lot many guidelines they also asked to just stop taking immunosuppressants to stop the risk of infection. But over the time, as as we kept on gaining information and as we became more and more knowledgeable about it, we finally got to know that even these immunosuppressants they can be useful to some extent in managing severe COVID infections. There are a lot many questions which always keep on, and even today, while so many physicians and so many medical healthcare practitioners they are treating so many COVID patients, they are always facing this problem whether I should use an immunosuppressant. Yes, no, maybe, don't know. So there is a continuous havoc which is regularly going on. So to manage and to these COVID infections and to provide the best healthcare support to the patients and have the best decisions, we have organized this particular webinar, which is on treatment guidelines for COVID-19 and special with a special focus on the immunosuppressants like Tofacitinib. So on behalf of Intas, I welcome all of you in this live webinar in which we have a wonderful speaker with us. That is Dr. Anshul Goel, sir. He is MD in medicine and he is a fellow in rheumatology. He is currently practicing as a consultant rheumatologist in Himachal Pradesh and Pathankot. And he will help us to understand the role of JAK-STAT inhibitors in COVID-19 treatment so that we can manage our patients in a better way and we can provide a better care to all the patients. Over to you, sir. Over to Dr. Anshul Goel.
Thank you, Dr. Amit. Thanks a lot. That COVID is very special infection, that it is not only infection, the infection is taking you to autoinflammatory and autoimmune syndrome. So we have to balance where to give immunosuppressive medicine and when to give antiviral therapies. Because if you give immunosuppressive medicine early in the phase, you will increase the proliferation of the virus. So you have to make a very fine balance between antiviral therapy and anti-inflammatory therapy. So for that, we need to understand the pathophysiology of the virus. How does it act and how does it destroy the tissues? We all are horrified by this picture. This is happening all around India. Thousands of patients are dying daily. And that is why I urged your company to arrange this webinar so that we can prevent deaths. We are in a war. We are shortage of beds and oxygen. I myself have faced this problem. And I know how difficult was it and how difficult it is now to carry on in this scenario. We must act very fast and rapidly. We should not see this situation tomorrow onwards. That is all we pray for. So first of all, let's understand what are the risk factors for severe COVID infection. We all are aware of this. Individuals of all ages are at risk of infection and severe disease, including children. But the probability of serious disease is higher in people above 60 years, those in nursing home and hospitals, having chronic medical conditions like cancer, kidney disease, obesity, immunocompromising condition, transplant patients, and pregnant people. In general, 14% of the patients require hospitalization, only 14%. 2% of them, they get admitted to the ICUs, and about 5% they die of the disease. So we have to cater this 14%. And that is our aim, so that we can save countless lives. The percentage of patients who died was 12 times higher in those with medical conditions than in those without medical conditions. So people who have medical conditions have 12 times higher risk of getting complicated. So what is the pathogenesis of COVID-19? So there are two main stages. So first stage, early in the clinical course, the disease is primarily driven by replication of COVID virus. That is very important. Early in the disease, there is replication. Later in the clinical course, the disease appears to be driven by dysregulated immune and inflammatory response to coronavirus that leads to tissue damage. So first phase, early stage is replication, second stage is inflammation. So antiviral therapies would have the greatest effect early in the course of disease, while Immunosuppressive and anti-inflammatory therapies are likely to be more beneficial in the later stages. So late stage would be of immunosuppressive medicines. So now we are facing another problem of mutations. We know that the second wave has got mutated virus, which has double mutation. So like other RNA viruses, SARS-CoV virus 2 is constantly evolving through random mutations. So whenever any new mutations happen, they increase or decrease infectiousness and virulence. Mutations can increase the virus' ability to evade adaptive immune response from past coronavirus infection or vaccination. And this may lead to an increased risk of reinfection or decreased efficacy of vaccines. That is why in the second wave, we are seeing that vaccinated people are getting infected, though the people getting serious infections or getting into hospitals is very low. We know the grading of disease: mild, moderate, severe, and critical. Mild disease happen in 81% of the patients. Mild and moderate disease. Severe disease happen in 14%. And critical illness, which is defined as respiratory failure, septic shock, multi-organ dysfunction, occur in 5% of the patients. So this is how we classified COVID patients. First is the clinical criteria. So clinical criteria by SpO2 respiratory symptoms. I will not go into the details because you are all aware of it. Again, CT criteria is also very helpful. And third is just a second. Yeah. And third is lab findings. Based on the lab findings, by your neutrophil lymphocyte ratio, CRP, ferritin, DDM, or LDH, you can classify patient as mild, moderate, or severe. So what is multi-system inflammatory syndrome in adults? So this typically happens in after 10 to 12 days after the onset of COVID symptoms. So this syndrome is different from cytokine storm syndrome, and it happens after 10 to 12 days. And I will not go into the details of this criteria, but the important point is that there is involvement of extrapulmonary organ systems, and there is absence of respiratory illness. So I will focus on the treatment of COVID disease. That is what we are doing. So the COVID treatment is rocketing science. A number of compounds are being evaluated. So Gordon et al. Identified 332 SARS-CoV human protein-to-protein interactions. That means he identified 332 methods by which we can stop the interaction between coronavirus and humans. Among these, they identify 66 human protein or host factors. So he identifies 66 human factors which can be targeted by 69 medicines, whether they are approved medicines or they are in preclinical compounds. That is very important, that there are 69 potential medicines which we can use in coronavirus disease. Whether they will work or not, that is a different matter. So how do we treat the mild to moderate disease? So we know that approximately 80% of the patients with COVID disease have mild illness that does not warrant medical intervention or hospitalization. 80% do not need any kind of intervention. No therapy has been proven to be beneficial in mild to moderate disease. There is no therapy. You have to provide supportive care. You have to take steps to reduce the risk of transmission by wearing a mask, isolating the patient. You have to advise patient when to seek in-person evaluation. That is when to visit a hospital. That is the main things we have to do when the patient has mild to moderate disease. What we need to learn is, if dyspnea develops, it tends to occur between 4 to 8 days after symptom onset. So these 4 to 8 days are very important. If patient develops dyspnea between this period, you have to ask the patient to meet a medical specialist as soon as possible. And the progression of dyspnea occur after a median of 2.5 days after the onset of dyspnea. That means when a patient develops dyspnea, after 2 to 3 days, the chances of getting cytokine storm or getting sick is very high. So this period is very important. We should ask patients that they should be careful between 4 to 8 days if they get dyspnea. So a new thing anti-coronavirus monoclonal antibodies. So they block virus attachment and cell entry by neutralizing the coronavirus. So these antibodies, they prevent the viral attachment and cell entry into the human cells. So whom to give this antibody? It is to be given in mild to moderate COVID disease who are at high risk for disease progression and in early stages of infection. So these medicines should be given only in mild to moderate disease and for those patients who have high risk for disease progression. Okay. And what are these medicines? There are three recommendations: Bavacizumab plus Adalimumab, Casirivimab versus plus Imdivimab. The important thing is very recently FDA has approved single dose of Bamlanivimab alone. So you can give Bamlanivimab alone in mild to moderate patients who have high risk of disease progression, like patients who have comorbid conditions. So how to treat patients who are hospitalized with moderate COVID but do not require supplemental oxygen? Okay, they do not need any kind of oxygen. Their saturation is normal. There is no use of steroid, either dexamethasone or corticosteroid. So we should not use any kind of steroid in these patients. The patients who are taking corticosteroid for other indications like rheumatoid arthritis or autoimmune conditions should continue therapy for their underlying conditions. Recovery trial, a very important trial, had found detrimental effect of steroids. So it found that if you give steroid in patients who do not need supplemental oxygen, patient can have detrimental effects. The use of Remdesivir may be appropriate in patients who have a high risk of disease progression, that who have comorbid conditions or whose saturation is rapidly falling. You may give Remdesivir to those patients. Okay, so at this stage, the only thing we can give is Remdesivir. Steroid should not be given unless the patient is desaturating. So in mild to moderate disease, there is no evidence of these medicines. These medicines are used very frequently by clinicians, but there is no scientific evidence of using these medicines. What are these medicines? Chloroquine or hydroxychloroquine with or without azithromycin. There is no use of this medicine. Zinc, vitamin C, vitamin D did not show any conclusive evidence in any of the studies. Dexamethasone or any glucocorticoid should not be used in mild to moderate disease. Anticoagulant, antiplatelet should not be started in mild to moderate disease. Any antibiotic, doxycycline, azithromycin should not be used and are not recommended. Lopinavir, ritonavir, or any HIV protease inhibitor should not be used. Now, what can we give? The patients who are taking ACE inhibitors for hypertension or statins, NSAIDs, or any kind of oral inhaled steroids, they can continue the medicines if they are taking for their comorbid condition. The patients who are receiving dexamethasone or steroid for their other indication should continue their therapy. So they should not stop taking steroids if they develop mild to moderate COVID disease. Like patients of autoimmune disease like rheumatoid arthritis, SLE, who are taking steroids should continue taking their steroid doses. The use of Remdesivir may be appropriate only in patients who have a high risk of disease progression, as I told you earlier. So what about patients who have moderate disease and those require supplemental oxygen by nasal cannula, but not through high flow device or ventilation? So you can give Remdesivir alone. So Remdesivir alone can be given who require minimal supplemental oxygen. Dexamethasone plus Remdesivir. It can be used for patients who require increasing amounts of oxygen, who are rapidly desaturating and whose oxygen demand is increasing. You can add dexamethasone to Remdesivir. In these patients, Baricitinib plus Remdesivir can also be used. It is also approved now. So Tocilizumab can be added to a patient's dexamethasone treatment in cases where the patient has rapidly increasing oxygen need and CRP levels above 75 milligram per liter. but does not yet require oxygen through high flow nasal cannula or ventilation. So that means you can add tocilizumab where the patient is rapidly desaturating and whose CRP is increasing. So at this stage, you can add tocilizumab. So this is a stage where we are giving everything. We are giving remdesivir, we are giving steroid, we are giving baricitinib, we are giving tocilizumab. This is the stage. If we act very diligently, we can save the patient's life. Now, those require oxygen through high flow device or non-invasive ventilation, but not invasive ventilation. That means patients who need high flow device or who are on CPAP, but who are not intubated. This is in non-intubated patients who are on high flow device and CPAP. You can give dexamethasone alone, or you can give combination of dexamethasone plus remdesivir. You can add tocilizumab to any of these who have rapidly increasing oxygen need and systemic inflammation. You can give baricitinib plus remdesivir. Okay, so in this stage also you can give steroids, remdesivir, tocilizumab, baricitinib plus remdesivir. The important is the combination of dexamethasone and tocilizumab may increase the risk of opportunistic infections or reactivation of opportunistic infections. You need to be careful of secondary infection. If you suspect secondary infection by any means or by cultures, you should not give tocilizumab or you should not give baricitinib. So these medicines should be given when you have ruled out the secondary infections. Now let us see the patients who require invasive mechanical ventilation or ECMO. Intubated patients. Steroids should be given, steroids should be continued. Remdesivir started earlier should be continued until the treatment course is completed. Okay. You have to complete the course of remdesivir when it was started earlier, when the patient was not intubated, when the patient was in oxygen. So continue remdesivir and complete the course. But do not start remdesivir afresh in these patients. Suppose the patient came to your hospital in intubated condition or on ECMO, at this stage, do not start remdesivir because two very famous randomized controlled trial, Act 1 and Solidarity trial, they showed that starting remdesivir did not improve the recovery rate in this subgroup of participants. Okay, so starting remdesivir afresh may not give you the desired results. Tocilizumab can be given in intubated patients, and recovery study reported a mortality benefit for tocilizumab. Okay, let's see individual drugs, what we are using here, what is the evidence, how to use. Vitamin C, vitamin D, zinc, there are insufficient data to recommend either for or against the use of vitamin C, vitamin D, or zinc. That means no recommendation can be made whether you give or you do not give. But remember, do not give very high doses of vitamin D and zinc as it can be deleterious to the patient. Remdesivir, what is this medicine? The big hype is made about this medicine. It is approved by FDA for the treatment of COVID-19. In fact, it was the first medicine to be approved by FDA for COVID-19 treatment. Remdesivir binds to viral RNA polymerase and inhibits viral replication. That is, it is antiviral. So, since it is antiviral, it should be given early in the disease course to inhibit viral replication. So, in the famous Act 1 trial, no observed benefit was seen in patients with mild to moderate COVID-19. Benefit of remdesivir was most apparent in hospitalized patients on supplemental oxygen. Okay, we have discussed it earlier. So no observed benefit in those on high flow oxygen, non-invasive ventilation, or mechanical ventilation. So in this class, continue remdesivir, which was started earlier, but do not start afresh. A trial was done in China. So no difference in time to clinical improvement or 20-day mortality or COVID virus clearance between remdesivir treated and placebo treated patients. WHO trial, remdesivir did not decrease in hospital mortality in hospitalized patients. Other trials, some trials showed mild benefit, some showed moderate benefit, but the recommendation is clear that you give to the patients who need supplemental oxygen early in the disease course so that you can reap the benefit in the right time. Steroids. Dexamethasone corticosteroid have been found to improve survival in hospitalized patients who require supplemental oxygen or who requires any kind of ventilation. We know this is a wonder drug, and whenever you suspect that the patient is passing into stage 2, that is inflammatory syndrome, start the medicine and it will do wonders. What about colchicine? This is act by anti-inflammatory method. We give colchicine in gout and crystal arthritis. We have seen its good anti-inflammatory action. There is insufficient data and uncertain benefit, and it may be harmful in hospitalized patients. Okay. Theoretically, it may act, but there is insufficient data and certain benefit. In corona trial, deaths and hospitalization were low when started earlier, but no recommendations can be made whether to give or not. About interference, IL-1 inhibitor anakinra, no benefit was seen in different clinical trials. Fluoxamine antidepressant, there is insufficient data to recommend the use of fluoxamine for the treatment. HCQ, hydroxychloroquine or chloroquine, no clinical benefit either for prophylaxis or for the treatment. We have seen that hydroxychloroquine was used last year extensively for the prevention of coronavirus, but now many clinical trials have shown that it does not prevent nor treat any kind of corona illness. So it should not be used. Ivermectin. Again, it is a very interesting drug. High concentrations, that is 100-fold higher than usual doses, what we use for parasitic infections. So higher doses act by inhibiting the these nuclear transport proteins. It prevents the virus entry and virus proliferation. Okay, so that is the main mechanism of action of ivermectin. In addition, ivermectin docking may interfere with the attachment of coronavirus spike protein to the human cell membrane. Small size and poorly designed studies showed no clinical benefit. So no recommendations can be made about the use of ivermectin in corona disease. Convalescent plasma. What is convalescent plasma? Is plasma taken from the patients who have recovered from corona disease or who are vaccinated. So you do a titer of antibodies in them, and if the titer is high, you can, it was proposed that it may give you passive immunity, not active immunity, it will give you passive immunity. So it may neutralize the virus spike proteins and it may cause neutralization of the virus. This was theoretical. But the expert panel recommends against the use of convalescent plasma for the treatment of COVID-19. Many studies were done, and the consensus is that it does not work that good as expected. You may not get very good benefit of using convalescent plasma. Earlier last year, FDA approved convalescent plasma to many patients. In fact, to all patients of severe corona illness. But after studying different studies, on February 4th, 2021, the FDA revised the guideline to limit the authorization of high titer convalescent plasma only for the treatment of hospitalized patients with COVID-19 early in the disease course, or patients who have the authorization of high titer convalescent plasma only for the treatment of hospitalized patients with COVID-19 early in the disease course, or patients who have impaired humoral immunity. Okay, so FDA said that you can use early in the disease or for impaired humoral immunity. But this is only FDA advice. All other bodies are contradicting and are not using convalescent plasma for the treatment of patients. Recovery trial, a very famous trial, did not find any benefit of convalescent plasma in reducing either the severity, mortality, or hospital stay. Several other trials were done, and they also did not demonstrate any efficacy of the convalescent plasma for the hospitalized patients. Now, another medicine, bevacizumab, it attracted a lot of attention. It is an anti-vascular endothelial growth factor inhibitor. What is VEGF2? It is a potent vascular permeability factor that induces vascular leakiness in COVID-19 infected lung tissues, resulting in plasma extravasation and pulmonary edema. So it was hypothesized that VEGF is more in COVID pneumonia, which is causing pulmonary edema and pneumonia. A single-arm trial was done, and it showed improvement in oxygen saturation and radiologic findings. Mortality or progression was not studied. So this is not recommended because it was a single-arm trial, a very small trial, and there can be confounding factors of steroids or other medicines which are used. So this was not a high-powered study. So bevacizumab is also not recommended for the treatment. This is a complicated diagram which is showing how the immune mechanism causes pneumonia and mortality. So based on this diagram, many medicines are proposed which can block the cytokines and treat the disease, like GM-CSF inhibitors, JAK inhibitors, IL-6 inhibitors like these IL-1 inhibitor, and anti-TNF, adalimumab. Let us see one by one. First, IL-6 inhibitors, interleukin-6 inhibitors. The prototype is Tocilizumab. In a big study of recovery and Remap-Cap, adding Tocilizumab to dexamethasone therapy. That means they used Tocilizumab with dexamethasone, was found to improve survival among patients who were exhibiting rapid respiratory decomposition, who required oxygen delivery through high flow nasal cannula or non-invasive ventilation. So they found that Tocilizumab plus dexamethasone was doing great in patients who required high amount of oxygen, or patients who are on non-invasive ventilation. Recovery trial and Remap-Cap are the two largest randomized controlled trial to date, which provided consistent evidence of its use. Some smaller trials did not show the benefit. The benefit of Tocilizumab occurs specifically in patients who are experiencing early and rapid respiratory decomposition. In moderate disease, the patients who are desaturating very fast and whose oxygen supplementation is increasing, if you add Tocilizumab to those patients, you will get the maximum benefit. Other IL-6 inhibitors like Sarilumab, there is insufficient data for the panel to recommend either for or against the use. So nothing can be said about Sarilumab. And Cetuximab, it was shown that it does not work. It is of no use. Now, interesting JAK inhibitors. Why JAK? What are JAK inhibitors? JAK means Janus kinase. The prototype is Baricitinib for JAK1 and JAK2, and FDA approved for the treatment of rheumatoid arthritis. And it is an oral tablet. It prevents signal transduction that leads to immune activation and inflammation with viral endocytosis, potentially preventing the entry of virus into the cells. This is theoretical, and this activity is possessed only by Baricitinib, not by other JAKs. So what are the recommendations? Baricitinib in combination with Remdesivir for the treatment of COVID-19 in hospitalized non-intubated patients who require oxygen supplementation. The trial which showed this benefit was Act2 trial, and it showed benefit of Baricitinib in combination with Remdesivir. So Baricitinib improves time to recovery in patients who require supplemental oxygen, but not invasive mechanical ventilation. And I'm elaborating about the Act2 trial because this is the trial which showed the conclusive evidence of Baricitinib. So Act2 trial showed that who required high flow oxygen or non-invasive ventilation like CPAP, the median time to recovery was 10 days in the Baricitinib plus Remdesivir arm and 18 days in the Remdesivir arm alone. That means if you add Baricitinib with Remdesivir, the patient recovered 1 week earlier. Okay. New use of oxygen or mechanical ventilation was less likely with Baricitinib plus Remdesivir than with Remdesivir alone. Serious adverse effects and new infections were low because the medicine was given only for 14 days. And Baricitinib has very short half-life. Cove barrier study. This is the very latest study, double-blind randomized placebo-controlled trial. 1,525 hospitalized adults. So this is a very huge number. The aim of study was to evaluate the efficacy and safety of Baricitinib in combination with standard of care for the treatment of hospitalized adults with COVID-19. Act 2 trial studied the combination of Baricitinib with Remdesivir. But this last study, studied the efficacy of Baricitinib in combination with standard of care. Standard of care means today you are using only steroid, Remdesivir, or Tocilizumab. So whatever you are using, so Baricitinib was compared in combination with standard of care. Most likely the standard of care was steroids. It showed a 38.2% reduction in mortality. Just imagine, just see this figure, 38.2% reduction in mortality. No increased frequency of serious adverse effects, infections, or venous thromboembolism. Because we always fear that if you do Baricitinib, then there may be increased venous thromboembolism or infections, but it showed that there was no increased frequency of these adverse effects. Baricitinib shows the largest effect size on mortality for any COVID-19 treatment when compared to other randomized controlled trials in hospitalized patients. So this trial showed the largest effect size on mortality. If you compare with Tocilizumab or Remdesivir, even Tocilizumab and Remdesivir studies also did not show such a drastic reduction in mortality. So this study was very encouraging to use in COVID patients. 38.2% reduction in mortality is not small. So Tocilizumab is not available in India, you know very well. Remdesivir is always short, and you will get it with great difficulty. Baricitinib is not available as of today. So what to do? What to give to the patient other than steroids? We do not want to see this picture. We want to save lives. You can see in this pandemic, two patients are getting beds. The shortage of oxygen. What to do now? We are desperate to treat patients. To our rescue, a new medicine has potential effect. That is Tofacitinib. It has got great potential. Because I myself have used this medicine and found very good results. Many people, many rheumatologists and other physicians are using this medicine who are reporting that this works very well if you give at the right time. When you need to give Baricitinib, instead of Baricitinib, if you give Tofacitinib, you will have good results. So how does it differ from Baricitinib? JAK inhibitor Tofacitinib is selective for JAK1 and JAK3. Baricitinib was JAK1 and JAK2. Several clinical trials to evaluate the effect of Tofacitinib are underway. There are many clinical trials which are undergoing. The recommended dose is 5 to 10 milligrams twice daily. It is very inexpensive medicine and very easily available. So this is the good news. This is a very recent study published very recently. Anti-inflammatory treatment of COVID-19 pneumonia with Tofacitinib alone or in combination with dexamethasone is safe and possibly superior to dexamethasone as a single agent in this African American cohort. So what it showed, a total of 44 patients expired on out of 249 eligible patients. 14 in the Tofacitinib group and 30 in dexamethasone group. That means Tofa patients, the patient who are taking Tofa, only 14 expired as compared to 30 on Dexa group. And it represents a 70% reduction in odds of dying. 70% reduction in odds of dying. So if you compile these studies, what we are seeing is the Baricitinib and Tofacitinib are very strong molecules which are suppressing inflammation and preventing mortality as compared to Tocilizumab or Remdesivir or other therapies. These are the trials. You can see how many trials are undergoing. These are at least 4 trials which are in phase 2, and very soon we will have the results. Now another molecule, anti-TNF, anti-tumor necrosis factor. So let us see the pathophysiology. The COVID infection is linked with pro-inflammatory status determined by high levels of different cytokines like these. We know this. So TNF is a pro-inflammatory cytokine that is intimately involved in excess inflammation. Levels of TNF are high in COVID-19 and predicts mortality. So if we block TNF, potentially we can suppress the inflammation. Anti-TNF agents are widely available and many affordable biosimilar versions are available. Adalimumab is a prototype of anti-TNF medicine. A study showed that patients with rheumatological disorders who were already on anti-TNF developed less severe forms of COVID-19. It was a small study which showed this effect. Terzi et al. Suggested that adalimumab may have beneficial not only in improving Crohn's disease, but also in treating COVID-19 patients. It suggested. It did not do a good study. Again, Conti et al. Reported a case. He reported a case. There are several clinical trials. We can see so many clinical trials which are underway, which are exploring the potential of anti-TNF, like with infliximab or adalimumab or etanercept. So many trials are underway. I thank you for hearing me. I thank INTAS.
This Baricitinib is approved by FDA only along with use with this Remdesivir. So should same be the scenario for Tofacitinib as well? Should we use it only in combination with Remdesivir, or it can be used alone as well? What is your thought on this?
So you can use Baricitinib alone as well. Anywhere. Use Tofa. You can start with 5 milligram BD and go up to 10 milligram BD. You should not stop the therapy. You need to give immunosuppressive medicine to the patient at the right time. So if you're not getting anything, start to Tofacitinib.
One more thing, sir, which was coming like nowadays there is a query that when patients use steroids, there are a huge number of cases which are coming with mucormycosis, and there is enucleation of the whole orbit of the has to be done as a surgery for management of that, and not many people are losing their vision. So in your current practice, do you see such a level of immunosuppression to increase the risk of mucormycosis with our other immunosuppressants, which might?
See, the hypothesis is mucormycosis is happening because of the water which we use in the oxygen humidifier. So it is being postulated that the water which we use in humidifier is contaminated, and when the patient is inhaling oxygen by nasal mask or anything, the mucor spores are going inside and causing mucormycosis. And if you see, the frequency of mucormycosis is very low. Okay, so we should not withhold immunosuppressive medicine for the fear of mucormycosis. For example, we are using immunosuppressive medicine in rheumatoid, vasculitis, SLE. They're using full doses of immunosuppressant. We are not fearing that the patient will develop mucormycosis or patient will develop any other opportunistic infection. So COVID is also a very deadly disease with very high mortality rate if the patient is in hyperinflammation. So at present, we should not fear of mucormycosis. If patient needs immunosuppression, give full immunosuppression so that cytokine storm or hyperinflammation can be controlled, so that we can save the life of the patient at the right time. If patient develops mucormycosis, then it can be tackled accordingly. But
Anshul, thanks for a very elaborative presentation. This is Dr. Amit Gupta.
Thank you. Thank you. I'm fine, sir.
I just wanted to ask you, what is the exact, what will be the good time to start TOFA vis-a-vis steroids? Suppose a patient develops hypoxia, we will start with straight away with steroids. And at what time after starting steroids should TOFA be added? And second question, what about the duration of this therapy?
Yeah, sir. When you have started the steroid to the patient, when the patient when the patient is desaturating, so you can see the benefit of steroid. If the patient is improving on steroid, you may continue it. But the moment you judge the patient is not improving, his oxygen demand is increasing, then you can add tofacitinib immediately. So you have to judge the patient. Suppose the patient is not progressing, he's improving only on steroid, then you may not give tofacitinib. But the moment you see that the patient is not improving and the patient may progress, you can add tofa. And the recommendation for baricitinib is for 10 to 14 days, and the same goes with the tofacitinib.
And what about the dose for TOFA? Suppose we start with 10 BD and the patient is clinically responding. Should we decrease after 3-4 days, or we should give the same dose for 10 days?
So there are no recommendations. My personal feeling is you start with 5 milligram BD. You start with 5 milligram BD. Tofacitinib works very rapidly. It works like steroid very rapidly, and it has got very short half-life. If you feel that the 5 milligram BD is not working that good, you can increase it to 10 milligram BD.
Okay.
And later on, when the patient has responded, you can again de-escalate to 5 milligram BD.
And after how much time should we de-escalate? Wait for 5 days?
So de-escalation can be done when the patient has become stable. Okay. Like the patient, if the patient is on CPAP and the CPAP is out and the patient is on high flow nasal mask, then you can start reducing the dose of tofacitinib. But it should not be reduced below 5% BD, 5 milligram BD.
Okay, thank you.